Sickle cell disease. Welcome to the Everything Surgery podcast, where we delve into the complexities of medical conditions and unravel their mechanisms. Today, we're exploring sickle cell disease, a classic example of a molecular disease. It was the first disorder to be understood at both the genetic and protein levels. The pathology of sickle cell disease arises from a single-point mutation in the beta-globin gene, yet its clinical consequences are widespread, affecting multiple systems. These include vaso-occlusion, hemolytic anemia, inflammation, and progressive organ failure. Let's walk through the details of this condition, beginning at the molecular level and tracing its impact all the way to end organ damage. Let's start with the molecular lesion and the changes that occur in red blood cell shape. The genetic basis of sickle cell disease lies in a single nucleotide substitution from adenine to thymine in the 6th codon of the HBB gene located on chromosome 11. This mutation results in the replacement of glutamic acid, which is hydrophilic, with valine, a hydrophobic amino acid. When hemoglobin S is present and oxygen levels drop, the hydrophobic valine interacts with a complementary pocket on a nearby hemoglobin tetramer. This interaction causes hemoglobin S molecules to cluster together, forming long, rigid polymers known as tactoids. These polymers physically distort the normally flexible, biconcave red blood cells into rigid, crescent-shaped sickle cells. Initially, this process is reversible if oxygen is restored, but after repeated cycles of sickling and reoxygenation, the cell membrane becomes irreversibly damaged, resulting in permanently sickled cells. The pathology of sickle cell disease is driven by two major, interconnected processes, hemolysis and vaso-occlusion. Let's break these down. First, we have hemolysis and endothelial dysfunction, often referred to as the hemolytic phenotype. Sickled red blood cells are fragile and have a significantly reduced lifespan, about 20 days compared to the normal 120 days. This leads to chronic destruction of red blood cells both within and outside blood vessels. Free plasma hemoglobin, released during this process, acts as a potent scavenger for nitric oxide, a molecule essential for vasodilation and inhibiting platelet aggregation. The reduction in nitric oxide bioavailability results in systemic vasoconstriction and activation of the endothelium, which can lead to complications such as pulmonary hypertension and priapism. The second process is vaso-occlusion, known as the viscosity phenotype. This is the hallmark acute event responsible for pain crises, also called vaso-occlusive episodes. It's more than just a blockage of blood flow by stiff cells. It involves a complex cascade of inflammatory adhesion. Sickled reticulocytes and mature red blood cells express high levels of adhesion molecules, such as V, CAM1 and P-selectin. These cells stick to the blood vessel wall, slowing the flow enough to trigger local hypoxia. This hypoxia causes further sickling and polymer formation. Eventually, a traffic jam of irreversibly sickled cells and adherent leukocytes, especially neutrophils, forms behind the adhesion point. When the microvasculature becomes completely blocked, ischemic tissue necrosis occurs, resulting in an acute pain crisis. Another critical aspect of sickle cell disease pathology is the vicious cycle of ischemia-reperfusion injury. When a vessel is blocked, tissue experiences hypoxia. If the vessel reopens, reperfusion brings a massive influx of inflammatory cells and oxygen radicals. The result is oxidative stress and sterile inflammation, leading to systemic leukocytosis and elevated levels of inflammatory cytokines like interleukin-6 and tumor necrosis factor alpha. This chronic inflammation damages the endothelium, making future adhesion events more likely, even when patients are not experiencing acute pain. Let's discuss the spleen pathology, which results in functional asplenia. In early childhood, the spleen filters out rigid sickle cells. The splenic cords are hypoxic, so massive sickling occurs inside the spleen, leading to repeated splenic infarcts. By the age of 2 to 5, repeated infarction replaces functional splenic tissue with scar tissue. The spleen shrinks and calcifies, a process known as autosplenectomy. This loss of splenic function means patients are overwhelmingly susceptible to encapsulated bacteria, such as Streptococcus pneumoniae and Haemophilus influenzae. The disease affects multiple organs in distinctive ways. In the bone marrow, compensatory hyperplasia occurs as the body attempts to produce more red blood cells, leading to expansion of the medullary cavity and characteristic radiographic appearances like the hair on end skull and fish mouth vertebrae. The kidneys, with their hypertonic and hypoxic medulla, promote sickling and can result in loss of concentrating ability. known as isosthenuria, and painless hematuria due to papillary necrosis. In the lungs, in situ thrombosis and nitric oxide scavenging contribute to acute chest syndrome, which is the leading cause of death in adults. The brain is affected by vaso-occlusion of large vessels or silent microinfarcts, increasing the risk of overt stroke and cognitive impairment. Bones and joints may suffer avascular necrosis of the femoral or humeral head, resulting in osteonecrosis, bone pain, and dactylitis in infants. Chronic hemolysis in the liver and gallbladder leads to pigment gallstones and complications like biliary colic and cholecystitis. Finally, in the eye, C-fan neovascularization of the retina occurs, which can cause vitreous hemorrhage and retinal detachment. The presence of fetal hemoglobin modulates the pathology of sickle cell disease. Fetal hemoglobin, composed of alpha and gamma chains, does not participate in the hydrophobic interaction that drives sickling. It acts as a diluent, physically preventing hemoglobin S polymers from aligning and elongating. Newborns remain asymptomatic until fetal hemoglobin wanes around 6 months of age. Hydroxyurea therapy is effective because it reactivates fetal hemoglobin production, reducing the frequency of polymerization events and pain crises. In summary, while sickle cell disease is traditionally referred to as sickle cell anemia, modern pathology defines it as a chronic inflammatory vascular disease. The triad of red blood cell rigidity and polymerization, endothelial adhesion and nitric oxide scavenging, and ischemia reperfusion injury with sterile neutrophilia explains why patients suffer from both acute microvascular occlusion and chronic end-organ failure, affecting the kidneys, lungs, and brain. Thank you for tuning into the Everything Surgery podcast. If you enjoy our content, please like, share, and subscribe. Join us as we continue to dissect the extraordinary world of medicine.